Hi, everybody. Welcome to another episode of ASAP Pathway Podcast. I'm your host today, Dr. Stacy Ochoa, and this is our first episode of season 2. And I couldn't have had the more perfect guest than Dr. Marie Morse today. She is amazing. I'm so excited. We literally have been talking for an hour pretty much before we even got on here. So I just have so much admiration for what she's doing and how vocal she is and educating the world really on the importance of sleep. But what I get even more excited about is she has the emphasis with pediatrics, which is so under discussed right now in the sleep realm. Actually, first of all, welcome.
Thank you. Thank you so much for having me. You're hyping me up a lot. It's a lot for
Oh
me.
my gosh, no, I not enough. I feel like I have this big bio, really impressive bio I could read on her. Check her out. It's DAMM, DAMM, and it's Dr. Marie Morse. That's where that comes from. I love the play. Damngoodsleep.com. She's all over TikTok and she's on Instagram. Love, love, love. How she's putting the education out there. So follow her if you could. Also, I have the honor of sharing a stage with her at Transform Dental Sleep in Scottsdale, Arizona. So if you are a dentist looking to get more into the realm of dental sleep medicine and how you can just have such an impact in your practice, attend Transform Dental Sleep in Scottsdale. It's going to be amazing. It's the inaugural event. It's going to be mind blowing, and I just had the honor.
Even if you're not interested in the dental sleep part, it's in Scottsdale in February.
Exactly. Just Scottsdale. I mean, and it's at such a nice, swanky, awesome place too. I can't even wait to be there. So just looking forward to sharing the stage with you. If you could tell us a little bit, I know I'm going to try to pack as much information as I can in the short time I have with you. Just tell us a little bit about yourself. Like,
Sure.
when you go to med school, was this what you always wanted to do, or did something shifted your gears to go neuro and pediatrics? So love to hear what your journey is.
Sure. So before medical school, my thought was adult neurology, and that's because my mom has a diagnosis of multiple sclerosis.
Oh, wow.
And before I started in medical school, I worked for a practice that was adult neurology, neuro-oncology, and pediatric neurology. And that really what transformed my journey to really transitioning to pediatric neurology. Once I went into med school, I was like, pediatric neurology is the way to go. The unique nuance of pediatric neurology that many people don't recognize is that pediatric neurology, unlike other specialties seen within pediatrics, is actually not a pediatric subspecialty. It's an adult neurology subspecialty. So
Interesting.
as a pediatric neurologist, I'm technically an adult neurologist with special qualifications in child neurology. I had no plans at all of pursuing sleep medicine until I actually was in my training. And the reason that I pursued sleep medicine was because as a neurology resident, I was going, every single patient has a sleep problem. Every single patient has a sleep problem. And as opposed to how most people will perpetuate the conversation around sleep as being a comorbidity, I was not seeing it that way. I was seeing it as part and parcel of the disease that I was managing. So you have epilepsy and you have a sleep disorder. For me to just say that's a comorbidity is really ignorant as a neurologist, because of the fact that if I don't treat that sleep disorder, your seizure disorder doesn't get any better.
It's
Right?
so interesting that you say that. My son had his first grand mal seizure. People that know my story, he was on a choir trip. He was literally a 24-hour bus ride from Missouri to New York. He had a history of migraines that just came out of nowhere, and then gets to New York, hits Times Square, has a grand mal seizure first, and God willing, last, hopefully, he's ever had in his life. He's now 20, and this was when he was 14. But the neurologist, I mean, this is part of my passion too, is like, you have got to get this sleep under control. And this neurological storm, there's just so much that the pillar of sleep influences. So back to what you were saying, like, you're like, I can't help you here unless I'm helping you here.
Exactly. And so, although when we think about sleep medicine, and you and I are going to have this conversation about sleep disorder breathing, the reality is that there still is a mistake when we talk about sleep disorder breathing. Many people think about it as a lung disease or a pulmonary disease, but at the end of the day, again, it's still a neurologic disorder. And the consequence and what actually generates sleep is neurologic in substrate. So it's the brain. The brain is
Yes,
driving
ma'am.
whether or not you're having healthy sleep or unhealthy sleep. And so therefore, as a neurologist, I felt obligated to saying, this is a huge educational and care gap. I want to become more knowledgeable. So I actually then went into sleep medicine training for sleep fellowship. And I specifically wanted to go to a neurology-based training program. So I ended up going to Montefiore in the Bronx because it was a neuro-based program. And I'm so thankful I did, because it actually really has shaped my entire career trajectory. And so not only gave me a great basis and foundation within sleep medicine, but also very specifically in rare sleep disorders like central disorders of hypersomnolence, narcolepsy, idiopathic hypersomnia, Klein-Levin syndrome, things like that. And now that really is an area that I see both adults and pediatrics in, so really across the lifespan. Other sleep disorders, I tend to focus just on pediatrics, but really do a lot of research across the age range, across the disease states within sleep medicine, and am completely committed to transforming society's mentality around sleep, moving it away from I'll sleep when I'm dead.
Right.
And reminding them that you're only going to get there a lot sooner with that mentality, and really saying sleep is the tool I need to lean into to be the best form of me.
It's so true, because especially guys, when I talk to my male patients, they see sleep as a lazy, passive part of their life. I'm like, it's you are so far from understanding what the role of sleep is in your life. I mean, that's the powerhouse. That's how you're going to charge that battery. You're going to be your best manly self, whether it's, in the bedroom, whether it's out of the bedroom. Like, sleep is so important for your testosterone levels, for your memory, being the best at your job. So back to the neurology aspect, because something I'm a big proponent of within the ASAP pathway community, being dentists, we are very much also about early interceptive orthodontics. We just released a literature review looking at 9 different papers of the intervention of children that have pediatric sleep disorder as young as 3, OSA and sleep-related breathing disorders as young as 3, and intervention strategies that help them with their breathing and sleep. Super important. We know craniofacial development is part of that. However, there is a bottom line: sleep, breathing, it's neurology. And so we take a child that's, and some would even say, just because they're not breathing well at night, it's exacerbated at night, it's worse at night, but some of them still aren't even breathing well during the day. I get that as well. But I am very interested in the non-anatomical aspect of sleep-related breathing disorders. There's a neurological component. Why is that airway collapsing? Why can't an airway stay patent when it should stay patent, and during the day it stays patent? Why are we struggling so much? And so where do you see, I have so many questions for you today. Where do you see the role of gut microbiome with neurotransmitters and poor sleep? I mean, I'm seeing a lot of literature emerging on gut health and its role with sleep and modulating sleep and controlling sleep. Where do you see that? Do you see that exploding? What do you think?
So we actually did a postgraduate course at APSS, National Sleep Conference, last year about really kind of the exposome and sleep disorder breathing. And the topic that I was covering was the microbiome and obstructive sleep apnea, circadian rhythm disorders, obesity, and really discussing what is that intersection. And you're completely correct. One of the things that I think I would first kind of just lay the foundation on is, when we think about sleep disorder breathing in children, we generally think about prepubescent versus post-pubescent, right? Because you're dealing with very different phenotypes or different characterizations of the individual that makes that susceptibility. When we're thinking of the prepubescent child, we generally are thinking about tonsils and adenoids as being the main culprit. In post-pubescent, we really are seeing that obesity is the main driver. Now, because really the majority of people in the United States are obese, 75% of adults are overweight or obese, and 50% of children are overweight or obese. We're seeing that being the main driver in both components. Now, you take a step back and you go, well, not everyone who has large tonsils and adenoids have sleep apnea, right?
Right,
they don't
correct.
all have dysfunctional breathing. So there has to then be an additional layer.
Yes.
In addition to that, there are other features of individuals that have nothing to do with your weight, and nothing to do with your tonsils and adenoids. And those are your craniofacial features. It's
Yes.
going to be more narrow face, high arch palate. And many times those types of physical features also may be more prevalent in individuals who may have syndromic neurologic conditions due to developmental brain dysfunctions. And so maybe on the autism spectrum or have other neurodivergence. And what do we see in terms of their overall muscle tone? It tends to be low or floppy.
Yes.
So if I have low floppy tone in my arms, what do you think my upper airway looks like? Now, when we look at the literature that actually examines the neurologic contributions that occur in regards to being able to maintain your upper airway, that's really coming from your brainstem, right? It's your cranial nerves that are innervating your upper airway and also your tongue to be able to maintain appropriate position and appropriate patency. What do we see in children who have untreated obstructive sleep apnea? We see a selective reduction in the volume of the gray matter in their brainstem. What is the gray matter? That's where the nuclei of those nerves that are feeding those areas of your upper airway live. And so if I'm seeing that being compromised, what do you think it's doing to the functionality? And so we are creating a feed forward mechanism. Now, the challenge is that the reason you're not having these types of detailed conversations on a regular basis is we've boiled down the diagnosis of this condition that is represented by pulmonary parameters of there being an apnea or hypopnea that is measured by a polysomnography. We're now seeing in the adult literature some movement saying AHI isn't adequate. Maybe it's respiratory vulnerability, looking at the degree of oxygen desaturation. Again, still short-sighted because you're still missing the fact that this is a neurologic disorder and not paying attention to the arousal indices, the length of the episodes, the degree of desaturation. How long does it take for them to drop to 60? Are they having an event for 30 seconds and not arousing from it? That to me is a brain that's not that healthy. Now,
agreed. And then that's where we're also missing a lot of these populations. Like we have children that are being missed, falling through the cracks because of the algorithms of how we're doing this testing. You've got darker skinned people that might be missed, skinny women's disease, they're getting missed. You know, people aren't, this algorithm is definitely geared, it seems, more towards the obese person, male, really.
100%.
The obese male, but not the skinny women, darker skinned, or children. So where do you see, because the testing of identifying that a person is not well, we're just not there yet fully. So we're missing people. And you're hearing things about biomarker testing from David Gazal. We've got definitely a lot of interesting changes with sleep metrics, especially for children. PSGs are limiting in so many ways. They're cumbersome, they're expensive. We have access to care issues. Not everybody has access to that. What's the talk? Where do you see kind of the testing to capture more people to identify that people are really sick?
Sure. So I think first and foremost, before we jump to an idea of saying that we can identify the right biomarker, we need to have the right characterization of the disease, right? We've made this mistake too many times in medicine of saying that we're going to create this biomarker that captures about 60 to 70% of people with this disorder. And the reason why you're only getting that percentage is because the other people have a different form of the disease. And so therefore, until we're able to actually have a better characteristic and say, what is the comprehensive impact? Because when we're only looking at the AHI, we're not looking at the EEG, we're not looking at the ultradian cycling, we're not looking at the limb movements, we're not looking at the EMG, we're not looking at the EKG. We're leaving so much information
off
on
the table. Yes.
And that is the reason as a field on the adult side, we've gone to home sleep testing and said that we can put something on our wrist and a finger or just here on our chin and say, we have enough information because we can estimate the AHI, but yet still miss the optimization of treating of that disorder, not only of the actual sleep disorder breathing, but also the comorbidities that come along with it.
You know, that's another valid point too. So many valid points there. My brain's reeling right now because, and this is my stand, like I'm coming from an adult sleep component into the pediatric world and everybody just wants an HST for these kids. I'm like, well, first of all, you're assuming that their issue is 100% airway, and there are over 80 different sleep disorders. And the why PSG is the gold standard is we can get an EEG, we can get entitled, what am I trying to say? CO2, entitled CO2. And it's so important to look at, like, I can't tell you how many exhausted children I've seen. And I'm like, this is not, I don't really think this is your airway. I mean, I need to get you to the sleep physician. And they had nocturnal seizures they were having, and they're exhausted. And you're not going to see that if you don't do an EEG on a child. Like you said, we're missing so many points of this human.
In addition, recognizing that there's limitations to whatever studies we're doing. Now a company like Knox does have home testing that does have some limited EEG, which is adding to the mix. But if in children, part of the reason why home sleep testing isn't preferred or utilized is not because we don't want it to be more convenient for the child, but they're more likely to be not a desatter, but an arousal, a respiratory event arousal. And so therefore, you're going to miss out on all those kids. And so I do think that there are some challenges. Now, I have taken us completely down a different path from the original question that you asked me, which was about the microbiome.
Yes, back to the microbiome.
Microbiome, I have to tell you, I have a completely different appreciation of the microbiome. If you talk to me as a young, naive resident, when I first was introduced to the microbiome, I was very arrogant. I was like, there's no friggin' way that some germs in my belly is telling my brain what to do. I'm a neurologist. The brain is the pinnacle of everything we do. And so now I will tell you, I was completely wrong. And the germs in my belly, 100% are telling my brain what to do. And so what had brought me to this? Well, when you look at the depth and breadth of literature about the microbiome, you're correct. It's exploding. There are 5 pivotal experimental designs that first really illustrated the role of the microbiome across all health processes, but especially neurologic processes. And for the ones that I think are really most impressive are the germ-free models that were utilized in animal models, where essentially it's birthing a animal model in a sterile environment through a cesarean section. So they're not being exposed through the vaginal canal.
Right. Getting that inoculation. Yeah.
And then also in the sterile environment, so that this way they're not getting exposed to anything else. What did they identify with those individuals? So these are individuals, they know their genetics, they know they're not susceptible for anything else. They identified that the brain is unable to actually develop the way it's supposed to.
Good grief.
The synaptogenesis as well as its myelination patterns are greatly abnormal, resulting in severe developmental brain dysfunction and neurodivergence. And so that to me, I was like, oh my goodness moment when I'm thinking about the number
all the C-sections and
increasing in terms of C-sections.
Now, I've always heard they're supposed to take the mother's vaginal bacteria and inoculate the child's mouth and nose and everything with that. Like, is that not happening?
I don't know that I've ever witnessed that when I have been in a delivery.
Interesting.
And so I can't say that that's something I'm familiar with, but I would have to consult with my gynecology and OB colleagues and my neonatal colleagues. But I can't say that in the deliveries I've been in that I've ever witnessed that. But
okay,
I hadn't been noticing it. Most typically, they take them out and they hand it over to us. So I don't know that is happening now. There's other models that have been looked at, and whether it was selective introduction of microbiome or antibiotic exposure, et cetera. A lot of these things are things that are happening on a regular basis for all of us. Now, how does this play into how the microbiome actually makes a difference? So is it actually the bugs in my belly telling my brain what to do? Not necessarily in a direct format. Many times it's indirect, either through our enteric nervous system or vagal nerve or some other forms of neurochemical communication. And what have we learned in regards to sleep disorders? Well, number one, the microbiome is dysfunctional in most sleep disorders. And so when you look at sleep disorder breathing, it's a fascinating relationship and one that does need a lot of attention. Why? Because dysfunction in the microbiome by itself causes chronic intermittent hypoxia and sleep fragmentation. You have obstructive sleep apnea and oxygen desaturations, that is going to cause a dysfunction in what the variety of different bacteria and fungi that may be in your microbiome.
It's this vicious cycle.
Exactly. Now, when you throw in additional sleep disorders like circadian rhythm disorders, it further creates even more dysfunction because number one, in 2017, as a reminder, the Nobel Prize went to 3 men for their monumental discovery and characterization of clock genes. And clock genes are circadian genes that every single cell in your body have. And so although we think about circadian rhythms as our behaviors of day-night rhythms, every single cell in our body have a circadian expression to what they do.
That's just mind-blowing. This was 2017 that they were...
They got the Nobel Prize. And so now when you talk about the microbiome in humans, there's also a circadian expression to that microbiome, which is one of the main limiting factors to why microbiome science in humans is a little bit more challenging than in rodents, because they're able to do rodents, they're pooping all the time. I can look at it every second of the day. For humans, I know for most women, we're not pooping on most days. So never mind multiple times a day. And so therefore they are creating new types of pills and things that can be taken that then can do sampling. Now the challenge with that is it's going through my GI system.
Yes.
Biome in my mouth is different than my esophagus and then stomach than is in my small intestine than in my large intestine. I'm dealing with different pHs. I'm dealing with different things that should be there. And so with that stated, I think that there is a huge opportunity for microbiome science, both not only the characterization of the microbiome in diseases, but microbiome in a healthy state, and understanding the selective reductions or over exaggerations, and then being purposeful in either the replenishment or the decrease in those areas. Now, with that stated, also recognizing that food is a part of a healthy microbiome.
Yes.
So whole foods are really very important. Fiber is a probiotic. It's something that is feeding our microbiome to maintain that healthy diversity.
That's so interesting that you were talking about. I'm so glad you're getting into the diet too, because we just had Dr. Susan Maples on. She's just gave a lecture for ASAP, and it said, my kid is pooped, and what does their poop have to do with it? And it was, I'm like, I love your title, but just the amount of fiber. You know, you got all these kids eating mushy chicken nuggets, and you have all these parents who are like bringing special foods for their kids because, you know, they won't eat what everyone else eats and they don't make their kid. And she's like, look, your child will eat vegetables if they're hungry enough. You just have to quit. We have to quit. Actually, you have to be brave enough to get past that child whining and complaining because they didn't get their little dino nuggets, and have them start eating more fibers. But she was like, the amount of fiber is so important, but I did not know that fiber was a probiotic. And the other thing I've wanted to mention, and I was curious about, a lot of the studies with vitamin D were done on rats as well and rodents. But the difference between human models and rat mice, they're nocturnal. So do you see that as kind of a, I mean, it's definitely an eye opener, but you're looking at a nocturnal species versus a, you know, how we are definitely very different.
Sure. I mean, you mean specifically in terms of vitamin D or in terms of sleep
not research? Just, but even just if this, like, do you see the same circadian expressions in the rat model? Like how did they come up with that?
So in nocturnal animals, they're going to definitely have different circadian expressions because their equivalent of daytime function for us is going to be at nighttime, right? So they're going to have an inversion. I was going to respond in regards to the vitamin D. I would expect then that their vitamin D is going to be potentially at higher risk for being lower because they're nocturnal and they should be sleeping during the day. So they're not going to get the sun exposure. However, I honestly don't know how rodents get their vitamin D or how much vitamin D they need.
Well, what I had heard is the studies originally done on rats for vitamin D, and where they came up with the ergocalciferol D2 was based on the rat studies, because that's where they get their D, because they eat more like fungi and things like that to get their D. Whereas with humans, because if you think about it, for years they were prescribing D2, 50,000 IUs, D2 once a week. And now we're pivoting towards the D3 because, again, they were looking at rat models. And so it's interesting when you do, I mean, I think we learn a lot from them, but then it's like, okay, now we got to look at the human models because we're very, very different. But it's so interesting what's emerging with vitamin D and the gut biome, which is vitamin D is a bacterial growth factor as well. But back to diet, we have so many flipping additives and just so much junk in these foods that if we could just get to more, again, it's like being that brave parent that Susan Maples says is, you know, the whole foods is, I mean, I'm guilty of it. Like, you know, sometimes I'm like, what's fast? And, you know, she would, you know.
I think really what we're talking about here is just what is the big problem in general, right? So one of the things that I get frustrated with, and I say frustrated because frustration means I have an emotional reaction to something that I can't change or control, right? And so my emotional reaction that I can't change or control is the schizophrenic communication around sleep health on social media and even within scientific journals, et cetera. So for years, we've been talking about duration. We need duration. We need duration. Look at how many people are not getting the right duration. And then now there's new studies coming out saying, oh, it's not duration, it's regularity. And it's not the challenge I have with this is that it's never been an either or. Never, ever. That's like saying like breathing is more important than my heart pumping. Like, no,
right.
it's not an either
No, you need both. You need both.
So when talking about sleep health, it is talking about getting the right duration, getting the right quality, getting the right timing, and also looking at what is my quality and my wakefulness, because that can be a reflection of the dysfunction of sleep. Why do I make this framing? Because we cannot separate a 24-hour day, right? You cannot say that daytime is more important than nighttime.
Right.
The fact that all of it matters. Why is it then that our kids are eating like crap? And why is it that we're eating like crap? Is because we're trying to jam more in a 24-hour day than what actually is sustainable. And the goal is to have an open conversation, dialogue, not to stigmatize anyone about you're being a bad parent,
right,
or a child by giving this food or that food. We're all just trying to do our best.
Yeah, there's a lot of shaming. There's so much guilt with parenting right now as it is. If we could just have some conversations to change the trajectory of how we're living and how we're raising these kiddos without the shaming, without, like, how can we have these conversations?
Well, I think that there's a lot of conversations that are occurring that are being spoken in absolutes. And one of the things that I think is really important for us to remember in medicine and in dentistry is that there are zero absolutes. There are zero. And so the reality is that we're, again, in this very schizophrenic, two-faced world where we go, personalized care. Everyone should do this.
Yes, right.
No, that's not how it works. And so I think that there are some generalizations that we want to make of saying, like, we want to see people eating more healthy foods. We want to see people getting more regular sleep. We want to see people getting more of their age-appropriate duration. We want to see better quality. Now, let's talk about what are some tips and tricks to get you in that direction, recognizing that it's not going to flip overnight, and progress. We are all on that journey of the better form of who we are today. If we have moved from being better than who we were yesterday and being a better parent than the day we were before, and the same for our children, and we're modeling that, then you're winning every single day. Now, I think that when we're talking about how do we incorporate more whole foods, I think it also is important to say what's realistic for your
what's going to actually happen.
What's realistic for your budget? Because at the end of the day, that also is very important. And so we now create these further stigmas. And so one of the things that it's funny, I say this and many people kind of look at me with two heads when I say this, is some of the phrases that drive me crazy are when people in administrative or in higher positions talk about, like, we need to focus on social determinants of health. We need to focus on diversity, equity, and inclusion. Not because I'm against those topics, but because many times what comes after them are the most stigmatizing and obstacle-laden conversations that actually don't solve the problems, because it's not
and don't get anywhere.
People. It's not incorporating the people who are experiencing it. So I think, like, the steps that we can take back is saying, what's your typical diet in a week? I'm a big fan of telling people let's do symptom mapping. Let's do lifestyle mapping. Let's see what your typical journey looks like. Now let's see what's actionable within it. Because for me to just pretend like I know you better than you know you and your life and what's realistic is not going to work. What I'm here for is to give you options and create accountability.
I think that's beautiful, what you just said, because I think most patients, it's so interesting. I think the patient-doctor relationship is changing. If you go back to, like, our grandparents and then our parents, it was like you walked in the room, you didn't ask questions, you just shut up, you did what your doctor said. And then it became, it was very dictative, like, I'm going to tell you what to do. And
I'm the paternalistic model of care.
Very.
I'm going to tell you what to do. Don't challenge me.
Don't challenge me. And don't be an advocate for your own health. And now we're definitely seeing a paradigm shift in the patients being their own advocates and not being afraid to, please tell your physician or your dental sleep specialist, please tell them how you're feeling, and don't think, I know that they're crunched for time and you feel like you're kind of hurried out of the room, but that is your dedicated time with your physician, your doctor, to ask those questions, or because they don't know what's going on in your life. If you don't tell them what's going on in your life, they're making assumptions unless you say, actually, a lot of things have changed.
Yeah.
So having those dialogues and physicians, all of us walking into that room and reminding ourselves, okay, brand new person I'm seeing, get the other 15 people I just saw out of my head, and just being more present and listening to what that patient has to say.
Yeah.
Because we can miss it.
The best gift you can give someone is being present, right?
That's so true.
And so the reality is that we are trained in medicine to have preconceived notions on everything, right? We're trained to know the answer based on one sentence, and to always have the right answer. And the reality is that in medicine and in dentistry, we need to be brave enough to break free from this illogical concept of this godlike complex that we always have the right answer, and that we're going to be able to generate a specific answer within the 20 minutes, 30 minutes, even an hour that we may have with a patient. What you need to generate is a partnership and a plan of how we're going to navigate this moving forward. And so I think that, as opposed to the current transactional episodic care, really looking at how do we provide and create these longitudinal models that are more continuous and reflective of the patient's wants, desires, and needs, by utilizing what our expertise is in the diseases, the medications, and the testing to help them navigate it. We are not there to tell them what to do and what great looks like. They're there to tell us what their needs are, what their deficits, and being able to get to that need, and asking us for their partnership to be able to facilitate an easier journey. And so I think once we start breaking away from this idea that patients are multiple choice questions that have one right answer,
right,
and that you're a bad physician or advanced practitioner for not selecting the right bubble in the Scantron, then I think we are going to start seeing that outcomes for patients get better. The role for the patient, which is that they should be educated and active and engaged in their own journey and helping to direct what it is that they need, that becomes much more robust. And that is going to lead to a natural transition of seeing that patients are only going to do better. And you can use this model in sleep medicine, in sleep dentistry, but you can also use it in any model of care.
I think we're going to have to see things change twofold, which what you're doing so well, which is educating the public on being advocates for their own health. But the culture of medical and dental schools has to change as well, because that, you're so right. It's you're a good doctor if you can walk in a room and nail what their problem is immediately. That culture is very real. Sure. How few things can the patient list, and then you come up with the outcome. I mean, that's just, we got to change the culture, even in how dentists and physicians are being pushed out into the world and have these different conversations.
Sure. Yeah, and I don't want people listening to this to mistake the idea that efficiency and accuracy should not be prioritized.
Correct.
100%, that should be still the case. However, we're doing it in a model that takes the human out of it.
That's it. It's humanizing the patient again. We've got to see them as this whole person that we're talking to. And that is the other thing too. You said it, and I know we got to go because you're one busy mama. What you said earlier is, it's not either or. We are such complex beings. And I know it within dental sleep, pediatric and adult alike, we can, especially as dentists, we're very mechanically, we want to fix things, we can be so narrow-minded that you've got to pull back and say, you know what, there's more to this. And it's not just this, it could be this. And they have restless sleep. Maybe their vitamin D is low. Maybe they have restless leg syndrome. Maybe they have a circadian disorder, a sleep phase issue. Before we go, I wanted to ask you what would be a take-home message? We have parents listening. We have practitioners listening. What's something you would really like people to understand more that maybe Monday would help more people get care?
So I think that going back to the basic concepts around sleep, right, which are that optimal sleep health comes with getting the right age appropriate duration. I emphasize that because it's not one size fits all. We typically are talking about the eight. The 8 is for 18 and older, 7 to 9 hours of sleep for that. When you're talking about teenagers, you might be talking about 8 to 10 hours. When you're talking about that brand new baby that just was born, that's 14 to 17 hours. So it's important to know age appropriate duration so you're shooting for the right goals. And recognizing the reason there's a range is, again, because even within those age ranges, it's not a one size fits all. The next is making sure that you're also looking at the timing of your sleep. Are you having huge swings in your schedule and you're having a sleep schedule in one part of the week and a different sleep schedule another part of the week? Or you're just going to sleep at abnormally late hours or abnormally early hours? And then the quality of both your sleep and wakefulness. Many times we are not acknowledging the fact that we're having chronic poor quality sleep.
Yeah.
We'll complain about it, but we're not acknowledging it and saying like, this is something I want to change. Or we're saying that, man, I feel sleepy all day and I'm yawning all day. I feel like I could fall asleep, or I feel more irritable. I feel more on edge. I feel like I could crawl out of my skin. Those very frequently can be signs of a sleep disorder. And so the question I commonly will get is, what is the difference between a bad night's sleep and having a sleep disorder? A bad night's sleep means that you had one night of poor sleep. When you start seeing that becoming a recurrent theme of poor quality, timing, duration, that's concerning for a sleep disorder. And that's your call to action to partner. I'm using that word specifically.
Yeah, I love it.
With your healthcare partner, right? Your physician or APP or dentist, to start finding out what's going on. What you can do as a patient to ensure that you're getting the right care is, again, start symptom charting, doing a symptom diary. What is it that is bothering you? Maybe you don't know right off the bat. Start keeping track of, what is my sleep schedule? What are the things that are bothering me? How many times am I waking up? How long is it taking me to fall asleep? What am I feeling like when I wake up during the day? Those things can inform the partner you have to give you the journey that is specific to what your needs are.
Love it. Love it. Everybody check out Dr. Morse at dammgoodsleep.com. Follow her on Instagram, TikTok channels. She's amazing. Love watching her. And she's adorable to boot on top of it. So she's one styling lady. I love it. Also, she and I will be sharing the stage at Transform Dental Sleep. So I was going to put a link for that. If anybody wants to register, you can still register. It'll be February 2nd and 3rd, 2024. I have 3 rapid fire questions before I let you go. One, what was your favorite sack lunch when you were a kid?
Peanut butter and jelly.
Oh, yeah. 2, were you Twinkie or Ding Dong team?
I was more of a Swiss roll.
Ooh, love the Swiss roll. That's a good one.
If I had to choose, I'd probably say the Ding Dong because that's closer.
Because you like more of the chocolatey. I was a Twinkie girl. Yep. And then favorite cartoon when you were a kid?
Oh man, there were a lot of them. I think probably like Ren and Stimpy was one.
Oh my gosh. Ren and Stimpy. Love it.
Yeah, definitely.
Well, thanks, Anne-Marie. I appreciate you so much. I know you are one busy person, and I'd love to have you back someday because we have so much more to say. So much more to say.
We're going to have you on our podcast.
Yeah. What's your podcast so people can check it out?
It's Sleeping Around a Podcast.
Sleeping Around. I love it. You have a lot of good plays on words. All right. Thanks so much for being here today. Appreciate you more than you'll ever know.
Thank you.